Hello friends, this is a case of laparoscopic cholecystectomy and here we will perform by a striker mini alligator. That means we will make only 2 port and one stab wound is given over the inferior crease of umbilicus and then we are introducing the varus needle and over the inferior crease of umbilicus. So, this is the 2 click sound and then we will do irrigation, suction and hanging drop test as usual to make it confirm that we are inside the abdominal cavity. So, this is over, we can see this ball is sucked in, that means we are inside the abdomen. Now, pneumoperitoneum is started and as usual we are keeping the preset pressure at 15 millimeter of mercury and waiting so that slowly actual pressure should reach to the preset pressure. And we can see now homogeneous distension is started and the abdomen is distended. As soon as preset pressure will reach to the actual pressure, flow will automatically stop and then you have to remove the varus needle. So, now almost distension is complete and we will enlarge the incision in a smiling way 11 mm incision to put the first optical port. And this is the optical port which we are introducing over inferior crease of umbilicus and this trocar is introduced. After that we will attach the tubing of the insufflator and increase the maximum flow rate to 10 liter per minute and now we will introduce the telescope and now this is the GP sternum and just below the GP sternum and slide towards the left we will put the second port, that only 2 port will be used and the third port we will not use. For third port we will use mini alligators. There are many company which is making mini alligators, Indian companies are also making and one of the famous is Striker. So, this epigastric port is also in and now we are ready to introduce a striker mini alligator. A striker mini alligator does not need port, it go percutaneously, just like how you are putting varus needle you have to give a small stab wound of 1 millimeter with 11 number of knife and then directly percutaneously you can introduce it and that will make your surgery only 2 port, you do not have to put third and fourth port. So, this is the mini alligator which is going and then you do not have to hold the fundus, you do not have to hold the Hartmann, you have to hold in the middle of the body of the gallbladder because this mini alligator has to be used for both the purpose for traction and for anterolateral and anteromedial traction. So, fundus pull and anterolateral anteromedial traction both has to be done by the same instrument. So, you have to be careful that a lot of traction you should not give, otherwise gallbladder will puncture. And now we are doing the posterior peritoneal dissection with the harmonic. If you are using harmonic, take care that always Teflon jaw of the harmonic keep towards the gallbladder, so that gallbladder will not puncture. And this Teflon jaw will act as a retractor that will keep the gallbladder and 1/3 of we are above the rovier sulcus we are separating the posterior peritoneum, giving the traction anteromedial and now giving the traction anterolateral. This is the anterior peritoneum is also separated and again Teflon jaw should just push the lever. After that we are removing some little adhesions over the cystic pedicle and separating all these omentum and duodenum down. So, there is a lot of fat that you should separate. Here we have also used ICG, indocyanine green, that we use in every case 45 minutes before the procedure we put ICG and that is 2.5 milligram. We dilute the auro green in 10 ml and we give 2.5 milligram. So, this is again little more anterior peritoneum is separated and now cystic pedicle is stripped down. So, this is a simple case, here there is no much difficulties, and slowly blunt dissection. Always we are above the Rouvier sulcus. So, this is safe. Time to time you can put in the ICG mode to make it sure that you are over the correct plane. So, we can see ICG mode is turning off and on, and cystic duct is visible nicely. So, it is properly skeletonized, keeping the Teflon jaw again towards the artery and duct, so that the knocking effect of harmonic will not accidentally puncture the duct or artery. So, it is skeletonized. After that we will use a Maryland. Posterior window is already formed, we can see here, and then Maryland will make the plane between. This is the posterior peritoneum is already little bit more stripped, and then you can make a window. So, this is the Maryland which we will use to make a window between the artery and duct. Few times the tip of the Maryland will be towards the lever, and once you have a plane, then introduce it inside and then put the convex edge towards the lever and hook the artery towards you. Because of a striker mini alligator, you cannot give a lot of traction, and because if you will give traction, it will puncture the gallbladder. So, you have to do this dissection by the Maryland itself. And now we can see this is the clip which we are using. Already you have seen that we have confirmed it by the ICG, and now this is the clip which is applied over the cystic duct. Here we are using the disposable clip applicator, and 3 clip you will apply. Distance between first and second is 3 millimeter, distance between second and third should be 6 millimeter, and then we are cutting it in between with the harmonic. As you can see, we are always above the Rouvier sulcus, and left hand is giving you the traction, that is the fundus pull as well as anteromedial anterolateral traction, both you have to give by the one instrument. And now this is the artery. Artery we will coagulate directly with the harmonic. However, you may clip it, but here we are coagulating the artery directly with the harmonic, that also is good. And now you can separate the, and you can relocate the striker mini alligator, and giving anteromedial and anterolateral traction, you can separate the gallbladder from the liver. So, you have to hold the neck of the gallbladder and rearrange the striker mini alligator, and then slowly you can keep on separating the gallbladder from the liver. Peritoneum fold should be cut first, and then body of the gallbladder with good areolar tissue you should separate. Light cable is kept down, so that you can see the gallbladder fossa much better. I will not recommend you to use the striker mini alligator for the 2-port cholecystectomy for the beginners, because a very nice anteromedial anterolateral traction will not be there, and Collard's triangle will not be as good seen as you are seeing in the 4 ports. So, 2-port cholecystectomy you should only perform if you have a good experience of performing the multiple port cholecystectomy, because it is not a classical surgery, it is just a modification. Patient has less pain, of course, because you have no extra 2-port is not there, but surgery need to be much more careful, and you should have the indocyanine green facility just to confirm that you have seen the CBD, you have seen the cystic duct, and then you are performing properly. So, this is just the last part where the fundus of the gallbladder is separating with little blunt dissection also sometime is useful, and then slowly gallbladder is getting separated from the liver. You can see there was no blood loss and bloodless surgery, and this is the final part of the separation of the gallbladder from the liver. You may do clipless cholecystectomy in this case, and epigastric port may be 5 mm only with the harmonic, but in that situation you have to take the gallbladder out through the umbilicus. So, here we are using 210 mm, but 2 port you may use one in the umbilicus and one epigastric, and you can use 5 mm telescope to take the gallbladder through the umbilicus. So, now it is over. After that, this is the claw forceps which we are putting from epigastric port, and now it will hold the neck of the gallbladder and it will be taken out. So, this is very easy surgery because case was simple, that is why we did by 2 port. Neck of the gallbladder is directly taken out. Here in this case we have not used any other port. Here stone holding forceps or claw forceps you will put inside the gallbladder, and there were multiple large stone which you need to crush to take it out. Otherwise, you have to enlarge the incision. So, this is ovum forceps which is crushing the stone inside the gallbladder, so that without extending the incision or without stretching the rectus sheath, gallbladder will be taken out. So, during this process of removal, we have slipped one clip over the liver, and after taking the gallbladder out, that last clip also we will take out. We have taken a note about that. However, even if you do not remove those clip, it will not harm, but sometime it may migrate to the wrong area, and that is why any slipped clip you should must take out. So, now gallbladder is almost empty with the stone, and crushing the stone with the ovum forceps. Very abrupt pulling without emptying the gallbladder should be avoided, because that way you can break the gallbladder and all the stone can drop inside the abdomen, and it will take a lot of time for you to just pick up all the stone by the stone holding forceps. So, now it is almost empty and then gallbladder comes out. Now, we are putting one Maryland from the epigastric port and we can see one titanium clip was dropped just over the falciform ligament during the process of extraction of the gallbladder. So, we will just pick up that and we will carefully take it out. So, this is the Maryland which is holding this clip and it is taken out. Thank you very much for watching this video.